Okay, what we're going to look at now is too fast from the bottom part of the heart. You know, we get the big hug. We love you because we love the ventricles, because those are our main pumps, right? It's our main pumps that pump to from the right to the left for oxygenation, and then from the left to the heart and the brain. So they're very key to our survival. So if we lose this, we lose 85% of our cardiac output. So we look at this rhythm strip, and the first thing we're going to say is this is a 6-second strip, so you don't need to count the boxes. We're saying it's 6-second strip. So how do you count the rate? That's right, count the R wave. So let's do that. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. So we take 13, we get my calculator watch out, so 13 times 10, and that's 130. Okay, and so that's not normal, but it does look regular. Now, is it wide or is it narrow? Is it coming from the top part of the heart or the bottom part of the heart? So if it's a wide complex, the QRS will be widened. You say, well, how do I tell where the QRS is? Well, I put a couple of bars up here so you can see where I'm marking that there at the beginning of the Q wave, when the wave first starts to go down, until you see kind of a hitch into the T wave. It's almost at the top when it peaks, and we'll say, hey, that's a beginning of the T wave here. There's a little bit of a hitch where it's a curve, and then it's sharp, then it kind of curves over to the right a little bit. You see a hitch at the top of the T wave on just about every one of those. And so that's where we're going to measure, and that QRS is about 5 boxes, 0.20. Some might say 4 boxes, but we'll call it 5 boxes at 0.20. So it's widened complex. So also we see here that our QRS complex is the facing downward instead of upward. And so it's downward and it's widened, and we're saying, hey, that's ventricular tachycardia. So when we see ventricular tachycardia, we should be saying, ooh, I better go check right away. So I could, you know, call and check on the patient. If I'm talking to the patient, does the patient have a pulse? Yes. So if I go check on the patient and actually see the patient, I would check the pulse. If the patient's unresponsive, I'd call a code blue and check the pulse and begin CPR. But if I check a pulse and the patient's got a pulse, or a patient's talking or having signs that they're alive, then I might get a set of vital signs and see what their blood pressure is and those kind of things, ask those next questions. Because if we have this on the monitor, it may not stay like that for very long. I remember when I had a patient that came in from EMS to the ER, and we got him in, and I was visiting with him, and he said, yeah, he wasn't feeling that great, but he was doing okay. And I said, okay, well, let's get you hooked up on the monitor. So we get up on the monitor, and I see this, and I go, he's like, we got to do something about this. You're in VTAC, you're in VTAC. We got to do something about it. And there was another nurse that was with me. She goes, what's the matter? It's like, look, he's in VTAC. And she's like, okay, well, just calm down for a second, because you want to be calm, so the patient will be calm. He's like, is there anything wrong with me? I said, yeah, there's something wrong with you. I'm ready to die here, buddy. So let me get an IV in you. And so trying to keep my hands calm from shaking and get an IV in. Got an IV in him and gave him some medications, and his rhythm converted. But he could stay like that for a little bit, but he eventually his cardiac output would decrease and would become a non-perfusing rhythm. So it is something that we definitely want to take care of and look at and address right away. Okay, so again, when we see that ventricular tachycardia, what's the questions we're going to ask? Is the patient stable or unstable? That's the main question. And so when we talk about stability, stability has to do with can we answer these questions? If they're yes to any of these questions, then we need to go to synchronized cardioversion. So After we check a pulse, what's a good idea to check? Right, a blood pressure. So see if it's perfusing with this and how well it's perfusing. We check a blood pressure. If it's low, we go to what? Right, synchronized cardioversion. If we're talking to the patient and their mental status has been changed, what do we want to do? Right, go to cardioversion. How about signs of shock? Yep, go to cardioversion. Ischemic chest discomfort. Yep. Acute heart failure. Are they having crackles heard in the lung fields? Is their heart failing as we talk to the patient? Yes, those would be all signs that, hey, yeah, synchronized cardioversion. So that would be our definition of what unstable is. Patient's unstable, just like with the narrow complex, we go right to synchronized cardioversion. Hit the sync button on, and then we'll shock the patient so it doesn't land on that's right, the T wave, the most vulnerable point of it. Okay, so what if the patient is stable or not yes to any of those questions? Are they hypotensive, signs of shock, ischemic chest discomfort, acute heart failure, all of those things, altered mental status, any of those things? If we say no, do not have any of those things, but we still have this VTAC showing up on a rhythm, what will we do? Well, there's drugs, pharmacology, medications that we're going to try and do. So amiodarone, we kind of talked about this when we did the narrow complex, because it can be used for both narrow and wide complex tachycardia. It has to have a filter. It's run in a bag over 10 minutes, and then we hang a bolus infusion for 6 hours, and then we run a continuous drip after that. So amiodarone is our main drug that we're going to give. That's the first one we're going to give. If amiodarone is not available, we can give lidocaine. And lidocaine is kind of an older drug that's been used a lot in the past, and there's just not a lot of studies to show that it improves outcomes. So, but it's very familiar with people, so a lot of people will use it, but amiodarone is our first line drug. If that's not available, then lidocaine would be next. Okay, and then procainamide would be next. And the procainamide runs a little bit differently, and you have to be careful with procainamide. So we would run procainamide, and it will help terminate the recurring VTAC, but we need to stop the drip if the arrhythmia stops. We would stop the drip if the blood pressure drops, and we would stop the drip if the QRS is prolonged more than 50% from its original duration. So if it was 0.20 and now it's increased, it's getting even wider, we would stop that. Part of our assessment always should be go in and check your IV infusions that are running. A friend of mine that was in getting a report in a patient, we went in said, hey, or the previous nurse said, hey, I just started the antibiotic to run on the patient, and looking and, hey, Mitch, can you help me look? I don't see any antibiotics given for this. Oh, really? Okay. That's odd. Let's go check. So we went in and checked, and the person had hung insulin to run over 30 minutes. And so they're getting 100 units of insulin IV over 30 minutes. And so that's not good. We save the patient, but we continue to have to give D50 through the night. But stresses the high importance of checking your drips when you first come in. Part of your assessment should be to check your drips. So come in, check your drips, see what's connected to your patient, do your dose calculation if you need to do that, and see if it's running correctly. So another drug is sotalol or beta-pace is commonly used orally. It's in the last few years started to be given IV And so you might see it in the ICUs. And so those are some of the pharmacology. Okay, and then too slow. So we talk about, this is the algorithm for bradycardia. ACLS talks about saying, hey, if you have a too slow rhythm, these are the general guidelines on what we're going to do. There's kind of one difference with the tachycardias is, remember we said that with the tachycardias, the 150, generally the heart rate of 150 is when you start seeing, and above is when you start seeing the tachyrhythm, you start seeing symptoms with them. With bradycardia, it's less than 50. Technically, bradycardia is less than 60, but generally you don't start seeing symptoms unless the heart rate's less than 50. Now, every patient's a little bit different. You might have an athlete that comes in and their heart is very efficient, so it beats maybe at 44 beats a minute, and it's very efficient. Boom, circulate. Boom, circulate. Boom. And we're not going to treat that, are we? We're not going to say, oh, we need to give you some atropine, we need to give you some drugs to get your heart rate up. No, because it's a very efficient heart. But on the same principle or same concept, we could have an older lady come in and she normally has her heart rate in the 90s or high 80s, and now her heart rate's in the low 70s or high 60s. And so that's a big change for her. And so we might treat her as bradycardic, even though technically she doesn't meet the definition. We would say that's a relative bradycardia, so it's relative to that patient. So we want to look at the patient and not just the monitor, not just the numbers, but look at the condition of your patient. So in this case, when we're talking about this and we ask this question, is the patient unstable or unstable? In tachycardias, if you remember, if we said yes to any of those questions, that's unstable, we go right to synchronized cardioversion. Here, if we say yes to any of those questions, then we're going to give drugs. If we say no to any of those questions, then we're just going to monitor and observe. So it's a little bit of difference between the two. One is saying, hey, unstable, we need to synchronize cardiovert. In this one, we're going to say, hey, we need to treat. So we need to treat with drugs and pacing. And if it's not, if they're not having any of these signs and symptoms, then we're going to just monitor and observe those patients. Does that make sense? Okay, good. Okay, and the same as the tachycardias, the bradycardias, we're going to do the same analysis of the rhythms. So is it regular? Is it sinus? What's the rate? What's the PR interval? What's the QT? What's the QRS width, and what's the QT interval? So we look at this and we say, okay, it's too slow, and we're going to get into the blocks and something like that in the next slide. But in this one, we're going to just look at this one and say, is this a 6-second strip? And we'll look and say, this one is, but we do have the boxes here. We could count if we needed to do that. But 1, 2, 3, 4 would be the rate. Is it regular? Looks like it is regular. And is there a P with every QRS complex? Yes, there is. And so the rate would be 40. So we'd do sinus Brady or SB 40. PRI is right at 5 boxes, 0.20. And then our QRS complex is right at 2 boxes at 0.08. And our QRS complex 0.08, and our QT interval is beginning of the Q to the end of the T wave, and that's about 2, 3, 4, 5, 6, 7, 8. So 8 times 0.04 is 0.32. Okay, is that what you guys are getting? Okay, good, good. And we're going to take that and then we're going to say, hey, let's look at the blocks next. Okay, and these are the typical blocks of first degree, second degree type 1, or Winky block or Mobitz type 1, second degree type 2, or Mobitz type 2, and third degree block, the complete AV block. So I'll talk about this a little bit. I'll kind of teach you how I was taught, and we can discuss it a little bit. The first degree block, we're going to look and say the PR interval that we're looking at is consistent. So every PR that we measure is the same distance. It's more than the 5 boxer 0.20, but it's consistently, like every PR interval I measure is exactly the same. So that would be a first degree AV block. The distance between the SA node to the AV node is being delayed for some reason. It could be damage, could be a number of things. It could be electrolyte imbalance, it could be electrical disturbance, it could be anything, which at this point we won't know. Second degree type 1 block. So first degree be like we're talking about a marriage between the P wave and the QRS complex. It's a little bit strained, and that's why we have the delay. Generally in first, second degree type 1 blocks, you don't see a lot of symptoms. In second degree type 2 and third degree, that's when you'll start seeing the symptoms. So second degree type 1, what's the characteristic is that the PR interval will get longer. So we'll measure it, and then we'll measure the one next to it, and we'll measure the one next to it, and then we'll see that it drops a QRS complex, and then it resets, and then it starts over again. So the PR interval starts out as, if we look at like about the middle of the strip, the third beat, we'll start at that PR interval, and then we'll look at the next one, and it's a little bit longer, and we'll look at the next one, and it's a little bit longer, and then we have a P wave and no QRS complex, and then we see it start over again with a P close to the QRS complex. So we have like a marriage that's strained. One of the people says something, and okay, he's sleeping on the couch, or he's staying with a friend that night, and so there's no QRS complex, and then they get back together, and you'll see that kind of cycle start over again. Second degree type 2 AV block, we'll see has consistent, just like the first degree block. Second degree type 2 is very consistent, but we're dropping a lot of QRS complexes. So they are putting up a front for children or whatever, but a lot of times they're not spending them together, unless it's for the kids' sake. So you have this atrial rate is 1, 2, 3, 4, 5, rate of 50 atrial, but would we say we don't have as much love for atria as we do for the ventricles? And so our ventricular rate is 1, 2, 3, so 30. So we're seeing a disassociation here, and our ventricular rate that's really perfusing the heart is only 30. And here's where we start seeing a lot more symptoms. And then the third degree block, we try and find the pattern, and then we find that the P, there's no PR interval that I can say consistently. It's kind of all over the place. So I'll start mapping the P to P to P to P to P to P, and that's all equal distance. And my R to R to R is all equal distance. So the P may be up into the T wave, maybe in the QRS complex, but you'll see that it consistently measures the same distance. And so there's a complete disassociation or a complete divorce from the P to the QRS. The atria are beating consistently, and the ventricles are beating consistently, but they have no relationship to one another. And so this is a cause for concern, because they can't maintain this cardiac output. It's going to drop, and it's going to be a problem. So that's kind of the blocks. And we'll talk about what you do about them, but that's kind of how you kind of see them. The first degree is consistent. Second degree type 2 is consistent. Second degree type 1, it gets longer, it drops 1. Second-degree type 2 drops a lot more QRS complex, and third-degree block has complete dissociation. P to P is equal and R to R is equal, but they have no relationship with each other. Okay, so what you see here is what do we give for the patient? So atropine would be our first line drug to give. What is the parasympathetic nervous system? Remember, the sympathetic nervous system is like our gas system, increased heart rate and blood pressure. It's a fight or flight response. Parasympathetic shuts things off. It lowers the heart rate, lowers the blood pressure. And so atropine works on the braking system. Instead of increasing the gas system, it doesn't do that. It increases it stops the ability to brake. So it cuts your brake line, and you can't stop your car. It accelerates down the hill or whatever. So atropine is a parasympathetic. It shuts off the parasympathetic nervous system and increases your heart rate by doing that. It does not work on denervated heart patients or heart transplant patients. And you must use it cautiously in somebody who's having an MI, or you must use it cautiously in the second-degree type 2 or third-degree blocks, as that may extend the blocks. But it's always going to be kind of a first-line drug to use. We're going to give it 0.5 milligrams IV push. We're going to give it, and we can give it every 3 to 5 minutes. The next thing we can do is transcutaneous pacing. And unlike it's the same patches we put on, but unlike the defibrillation where we defibrillate or synchronize cardiovert in tachycardia, you have to have the patches as well as your 3 leads on. So white to right, red to ribs, and what's left over goes over the left shoulder. So you have your 3 leads from your defibrillator monitor, and then you put it onto pacing, and you have your patches, and you have to be able to put those on correctly. There'll be pictures on the patches. We'll put those on, and we'll have our electrodes on, and then we'll pace. We'll turn the rate up to about 70, and then we'll increase our milliamps. The cardioversion was in joules, much larger, and this is in milliamps, but it's enough to cause capture. And what does that mean? And there's a little picture that shows on the bottom what capture means is that that little spike is occurring, and that should cause the contraction of the heart. And so doesn't matter what your pretty picture looks on the monitor, it matters what your patient's actually pulse is. So we would actually check our patient's pulse and see if this is capturing, so that when it shows 70 or 80 on the monitor, and when I check a pulse, it actually should be that I get 70 or 80 in the beats that I feel, because that would mean it's capturing. If it looks pretty on the monitor, but when I check for a pulse, there's no pulse, or it's only getting the pulse half the time, then it's not achieving capture 100% of the time. And we would keep increasing the milliamps until we get capture, or it may not be effective on the patient. But that's another thing we do. Atropine, then transcutaneous pacing, and that's always a bridge to transvenous pacing, meaning a central line would be placed and an electrode would be placed into the right ventricle on the inside, and that would pace the heart, and it wouldn't hurt. Transcutaneous pacing is going to give a stimulus. I hate to say the word shock because that makes you think of the other, in tachycardia. But it is a little bit of a stimulus. It hurts the patient, and you're thinking it's doing this 70 times a minute for the heart rate, and so they're getting this stimulus. So they may need to be sedated. They may need to receive some pain medication so they can tolerate this until a transvenous pacer can be placed where it's not going to hurt the patient, and eventually then they would have to have a pacemaker placed. Okay, and then dopamine as an infusion could be started. Atropine, transcutaneous pacing, dopamine infusion. And the dopamine is dose dependent, so at lower doses, like the 1 to 5, you have renal and mesenteric arteries that are dilated. Then at 5 to 10, it increases the heart rate and blood pressure, and then after 10, It's mainly increases the blood pressure, vasoconstrictive. But at the lower rates, it can be used for bradycardia, but it might lower the blood pressure if it's below 5 and raise the blood pressure if it's above 5. So heart rate should increase the heart rate 2 to 10 mics per kilogram per minute. Epinephrine is our sympathetic nervous system response. It directly stimulates that, increases heart rate, increases blood pressure, the fight or flight mode. And again, we're not giving it IV to a person that's alive. IV push, we're giving it through an infusion. So how we give it to a dead person, we give it IV push 1 milligram. How we give it to a live person is we take that couple of milligrams, put it in a 500 cc bag, a 500 milliliter bag, and then we infuse that. So we never give it IV push with the patient with a pulse. It's always with the infusion. And so it would increase heart rate, increase blood pressure. Isoproterenol is a drug that's, a lot of times you'll see it in the EP lab only. Occasionally you'll see it in the ICU, but it's kind of been out of favor because titration is so difficult with it. It's 2 to 10 mics per minute, but you'll increase the heart rate, but if you titrate it too quickly, it can really drop your blood pressure. So you got to watch it real closely. So we'll kind of, I'll mention that because you might see it in clinical, but it's not one that is commonly used. So here's a little saying: all tired dogs eat IMES, or all teachable dogs eat IMES. So A is atropine, T is transcutaneous pacing, D is dopamine, E is epinephrine, and I is isoproterenol. All tired dogs eat IMES. So if you're into sayings and it helps you remember the drugs, then we can use that. And here again, I'm going to just give you a few minutes to try and reflect on what's been taught. I would like you to be able to teach this to somebody else and make sure you have this. So I'm going to give you a few minutes to write this out on a piece of paper and teach it back to me, or teach it to somebody that you know. Good. Keep going. I'll give you about a minute more. All right, guys, we'll just go ahead and wrap this up. You guys have done a great job. Thank you.